So I think we have time for maybe 10 minutes worth of questions. I guess I could start. I wanted to ask Jeremy a question. So you said that, so I've used the Cellvizio before. I do advanced imaging too. And so you use the probe, the confocal probe, and you survey the entire surface of the stomach? Because that probe is very small, and how long does that take?
So no, and the reason why we use that system of 22, breaking the stomach up into 22 zones, was so that we could sample a small part of each of those zones, and at least get a sense that we've been able to look at the entire stomach. So no, within each of those zones, we may have, moved the probe around, let's say for a couple minutes, and then you move to the next zone. It's obviously one of those things. Somebody talked about optical coherence tomography, and that's a technology that I think I would love to use in the stomach, but I don't see a feasible way right now of doing that, right? So I don't think there's an optimal way to use the confocal probe. The one thing I will say is that in a lot of our data, most of the positive biopsies that we see come from the fundus, and I don't know if that's a genotype correlation or not, but we're tending to focus more time with the probe and the fundus.
Yeah, I want to follow up on that because I've done a ton of confocal in my past, and actually stopped using it because I found it somewhat cumbersome. And I am impressed that you're able to get around all over the place, because I felt that certain regions of the stomach are very difficult to image with the probe. And then the other question I had related to that and follow up on that is the duration of the treatment, because are you redosing with fluorescein? And because I find that that confocal is very time dependent, right? Because there's a lot of fluorescein leak, and that your interpretation might be skewed depending on what time. Like, are you imaging early or is it imaging later? Because the longer you're in there, you got a lot of fluorescein leak, and it gets very, very difficult to interpret.
Yeah, so to go back to the first thing, you're right. The confocal probe is cumbersome. And again, one of the reasons why me as a surgeon, I'm interested in it is because in order to study signet ring cells and in order to get to the point where we could do single cell analysis is we need access to those cells, right? And right now we can only find them once the stomach is out and it's fixed and formalin, and we lose some opportunities. So that's number one. Number two, in terms of the time, the actual confocal examination only takes about 30 minutes. We dose the fluorescein and we start immediately. In only a couple patients did we redose the fluorescein, but we didn't get a sense that the image quality changed dramatically, except in the beginning we were starting in the antrum and progressing proximally, and sometimes when we got to the proximal stomach we thought the image quality was getting worse. And since we believed that most of our positive findings were coming from the body or the fundus, we quickly thereafter changed and started up in the top of the stomach and worked our way down.
One other piece of advice: I'd try and find someone who does photoacoustic imaging. I think that's going to answer your question.
Greg, City of Hope. Thank you everyone for those wonderful presentations. Everyone's presentation on the dais was great. Question for Elena. So we've seen in cancer genetics there's been a movement towards testing everyone germline with breast cancer by the American College of Surgeons. NCCN has also put out a recommendation for testing everyone with pancreatic cancer. Now this is early detection session, and I'm just being provocative here. Do you think there might be a role of testing anyone germline with gastric cancer?
So I think that's a great question, and I think that some of the data that comes from large sequencing series of individuals with advanced cancer has demonstrated that the germline mutation rate in individuals with advanced cancer is about 10%. So I think at that threshold, anyone with advanced cancer probably would benefit from germline genetic testing, especially because of actionable therapies for PARP inhibitors and immune checkpoint inhibitors. I think gastric cancer is interesting because one of the questions that always comes up is that the world of colon cancer and the world of gastric cancer are very, very parallel. And I think that certainly if you have a young individual with gastric cancer, I would say absolutely they would merit germline genetic testing, because we're offering germline genetic testing to all young colon cancer patients. So I think that we should be offering germline genetic testing to any gastric cancer patient diagnosed under the age of 50, or any gastric cancer patient who has a microsatellite unstable tumor, or any gastric cancer patient who has a family history that looks compelling.
I also have a follow-up question for Dr. Stoffel. In the CDH1 patients that have lobular breast cancer versus the stomach cancer, is there a variant that you may say, oh, this variant looks like will be more predisposed to the stomach cancer, or it's just going to be a lobular cancer? I know it's not answered yet, but maybe your insight into this?
Yeah, not excuse me, not in our experience. And I think that there have been some attempts to look at genotype-phenotype correlation. And I think that in families, we see so much discrepancy, even in members of the same family. You know, like the family I showed you, there's one branch of the family where it's lobular breast cancer, and then the other branch of the family has signet ring cell gastric cancers in kids in their early 20s. So I think that the jury's still out on that. I think that, personally, I think that other potential environmental exposures or genetic modifiers might play more of a role than the actual genotype of CDH1.
Just one more question. In terms of the over the time duration or generations,
Yep.
do you see an earlier onset of, at the age of diagnosis of stomach cancer? So, you know, these are just anecdotal for me, but patients are coming in at age 34 and with CDH1 mutation with a family member that's an older generation, like a father, that they had cancer at 45, and then the older generation, the grandparents, had cancer at 65. And so then they find this out, but then they come and say, well, I'm only 35, do I need my stomach out? And it's a very tough question to answer. And then they're found to actually have advanced cancer on endoscopy and CT scan. So it's I don't know if that trend is across the board or it's random.
Well, I think that we don't know that there is or is not genetic anticipation in this condition, but I think that part of it is also ascertainment. You know, I think that if we're scoping these individuals earlier, maybe we're diagnosing them earlier than they would have been diagnosed anyway. And I think we really don't have a sense of the timeline for this disease.
I have a question for Dr. Stoffel too. Sorry. For the CDH1, you're probably going to see more VUSs. How do you manage those? Do you offer them endoscopy? And if you do, would you do the Cambridge protocol?
So it's interesting because what I've started doing with, so the questions about variants of uncertain significance in the CDH1 gene. And I think that we find these not uncommonly. And what I usually talk to patients is I say, well, there's this CDH1 germline variant of uncertain significance. We don't know what this means. One of the things we could do is a baseline upper endoscopy with, and I'll do Cambridge protocol biopsies. And then if that endoscopy is negative with no signet ring cells, I'll basically say, check in again in a year. We'll see if the variant has been reclassified. And it's unlikely that I will repeat the endoscopy at that time, but I think that just a baseline endoscopy is worth doing because, again, what if we found intestinal metaplasia or something like that, which would then put them in a surveillance?
All right, I have several questions for Blanca. A great presentation. You showed one slide that showed the difference between intestinal type and diffuse type and the presence of intestinal metaplasia. The one perplexing thing to me is for the intestinal type, why doesn't 100% have intestinal metaplasia? I would think that, you know, that we're saying that intestinal metaplasia is the precursor to intestinal type adenocarcinoma. I would think that all of that should have some intestinal metaplasia. Just like adenocarcinoma in Barrett's, we almost always see adenocarcinoma occurring in the background of Barrett's.
The question is on that. The question is on that biopsy that it was totally replaced by intestinal metaplasia, or what is the question?
The question is, why is, you showed a slide that said like maybe, you know, the best one was about 88% had the presence of intestinal metaplasia for intestinal type adenocarcinoma. I would expect that to be essentially 100%. Why isn't there intestinal metaplasia? Why doesn't
in all the cases?
Yeah, in intestinal type adenocarcinoma, why isn't it in the background of intestinal metaplasia?
Well, these are studies that are looking at the specimens after the gastrectomy, and I assume that it's not the totality, the 100% of the specimen evaluated. They took several sections and then go retrospectively or prospectively.
So you think it's just underreporting then?
I cannot tell you that intestinal metaplasia is the precursor in 100% of the tumors, but what we can see is that there is a clear transition between the metaplasia of the incomplete type and the dysplastic lesions. I didn't show any pictures because there was already enough time, but there are clearly an association. You see big areas of mixed, complete, incomplete. They're from the incomplete type. You can see a transition to the dysplastic glands. That's why we have one lesion called indefinite for dysplasia, because you start seeing that the nuclei are different, disorganized, more hyperchromatic, but it's not yet dysplasia. So it's like a big gray shades that go to the dysplastic lesions. And clearly we can see also in the specimens that the dysplastic lesions are in the surrounding area of the tumors.
So you mentioned this concept of incomplete type intestinal metaplasia, and especially in the U.S., pathologists don't like to report on this, right? We finally got our Stanford pathologists to report on that, and they're doing a fantastic job, but I think we're clearly in the minority in terms of reporting incomplete type of intestinal metaplasia. So 2 questions on that. If there's incomplete type and you're applying it to OLGM, is that equal to severe intestinal metaplasia or completely not related?
No, I forgot to mention that OLGA and OLGM don't include at all the typing. There are papers, and we show it too, that when there is extensive metaplasia, usually it's associated with the incomplete type. The more extensive, the higher the probability to find incomplete. But the subtyping doesn't have any influence on the OLGA OLGM.
So you could have mild intestinal metaplasia but still have incomplete type?
Mild metaplasia, very incomplete type. Yeah. Very rare, but yeah, it would be possible. Hypothetically, yes.
Because there's so much inter-observer variability, I think what we should do is we should do single-cell sequencing on incomplete versus complete, develop a novel molecular signal, and then we don't have to worry about this problem anymore.
You think you're going to find a signal there, Hanlee?
Yeah.
When? So I think your presentation, this concept, is actually the most clinically relevant, right? Because right now we're basing all our decisions on pathologic results with a lot of observer variability. What, as a clinician, and when I'm taking those biopsies, what I need to know is how am I going to risk stratify this patient, right? And I think that OLGM right now, OLGM and OLGA are the best possible ones, but again, they still have flaws, and then you take into account the distribution, and I completely agree with you. If even though you just have antral predominant, that's not low risk. It really depends on the severity of the intestinal metaplasia there as well. So, I mean, I think I need you to work a lot harder, Hanlee, and get us an answer, because I think that's what we need. We need a molecular marker or some other type of marker that really further risk stratifies intestinal metaplasia.
Yeah, I loved everyone else's talk explicitly because so I'm on the onc side. I get the consequences afterwards. But I found being updated about the latest criteria really enables me to sort of think about what level of resolution could I go to. So for example, in the context of CDH1, we've studied a series of patients where we have clear P53 deletions. Now, if I were able to get a hold of some of your samples, say, and be able to explicitly see a subset of those cells that are associated with signet cells, which I'm sure will have their own signature, but then identify that there's a P53 dysregulation or even a chromosome arm loss, then we're off to the races. And that actually matches what we see in the mouse models as well. So, and then I loved Bianca's talk because basically you've given me some classifiers now that are sort of generally considered, and I can say those are the 2 populations that if we get samples from those sets, I can consider not only transcriptional dysregulation, changes in cell type, pathway differentials, but even chromosomal abnormalities that, if accumulated in a subset of that, could be an indicator of something that's moving faster towards invasive carcinoma. So
Yeah,
I think I benefit the most from everyone else's talk, frankly.
Yeah, one thing in the aspect of getting biopsies for classification of complete, incomplete, or for doing whatever molecular studies, is that the lesions are very localized. I showed you like this entire biopsy, and in that entire biopsy, if I show you closely, there are complete glands in the middle, and the next there is an incomplete gland. Mm-hmm. So it's really, really mixed. And if you get the biopsy for molecular, you cannot be sure that that biopsy has complete or incomplete, because in the same patient, in different biopsies, you have different types. Usually what I have seen along the years is that the corpus, the oxyntic mucosa has more complete, usually is almost all the time is complete metaplasia. So there is something that is making these cells look different or differentiate different from other pathways. I don't know if it's because usually it's the antrum, the first lesion that starts the intestinal metaplasia, and if it gets along the years more mutations or changes, molecular changes, that starts to look more incomplete, and the lesions in the corpus actually, at least in the Colombian cohort, appear later, and usually are more the complete type.
Great, fantastic. Thanks, everyone.